Hello and welcome back to Investigator Insights Emerging Multikinase Inhibitors in Thyroid Carcinoma. Joining me once again is Dr. Marcia Brose from the University of Pennsylvania. So Marcia, we've covered the basics of the tremendous evolution in thyroid carcinomas in recent years. We've looked specifically at the development of sorafenib in the initial trials, and then the phase 3 decision trial, which, as you mentioned, has shown that there is a significant improvement in progression-free survival. More news at 11. So we'll just have to wait for the formal presentation, possibly at ASCO this year. But let's move on in this segment and talk about some of the other agents. It's almost like thyroid carcinoma is mirroring renal cell carcinoma, and some of the drugs that are already approved in renal cell carcinoma, sunitinib, pazopanib, axitinib, have also shown activity in thyroid carcinoma. So some of these are multi-targeted, whereas axitinib is much more focused on VEGF-R. So tell us about those agents before we move into other signaling pathways.
Well, so just like you said, in renal carcinoma, there was definitely good data. The difference from renal cell is that we haven't had all of the ones that show good phase 2 data move to phase 3. So axitinib did not move forward, at least not yet, into the phase 3 arena. So we still only have the data from the phase 2, which showed very nice activity, and mostly as a first-line agent because it was a very early study. Pazopanib also has wonderful phase 2 data. However, that is has not gone forward as well to phase 3. Lenvatinib, which is actually the one that has gone forward, has nice phase 2 data actually, and that has become the SELECT trial, which is probably another year out from our hearing about as far as what the results are. So we are going to have multiple agents, and the vast majority of these are VEGF receptor inhibitors. You'll see that seems to be the most common attribute of all of the agents thus far that have been studied and shown good phase 2 data. It turns out that sometimes you can get these off-label, but it's not always easy, and it's hard sometimes to get insurance coverage and not always supporting for patients. And at tens of thousands of $10,000 a month, it's not always possible, even though these agents are available. Without that phase 3 data and without the insurance companies covering them, we don't necessarily have access to all of the agents. So that's why it's really important that the ones that are active go forward to phase 3 studies.
So lenvatinib hits a number of other targets besides just VEGF-R. How important do you think those other targets are in its activity?
That's the million-dollar question. We really can't tease it out. We know that VEGF receptor inhibition is so active that it's hard to know how much those secondary targets are contributing. And at the end of the day, we won't know unless we actually can start, targeting things individually. And more, there have been more selective agents on the horizon who are now being tested. They're MEK inhibitors. There was a study of selumetinib, which is a MEK inhibitor, which was actually a negative study. So it didn't meet its primary endpoint by itself. And we'll probably need to come back to selumetinib because there's some other treatment strategies involved with that agent. But just as a phase 2 that was reported out of, I believe, is University of Chicago data that showed that at least it was not a significant. When you just target MEK by itself without any of the other activities, it didn't seem to work as well. So it's not always clear that having a clean drug and a nice, real sharp target is always going to be good. Although in VEGF receptor inhibition with, say, axitinib, it worked really quite well. So we know that that's probably number one activity. But how much, say, the BRAF activity in sorafenib or the KIT activity in many of these drugs or PDGF in some of them, how much that's contributing, we won't know. We only will know, I guess, is just how well it does overall.
Very good. So what about the mTOR pathway, the PI3 kinase AKT mTOR? You mentioned some of the mTOR inhibitors, temsirolimus and everolimus. How significant are these agents, and are they potentially frontline agents, or are they more applicable to a combination with one of the VEGFR agents?
Sure. So there's not really good data for everolimus or the mTOR inhibitors by themselves as a single agent. So for the most part, they've been used in the context of second line and maybe in combination with other agents. One of the limitations that's happened is that when you actually combine them with sorafenib, sometimes when you start the two together, the hand, foot, and the rash can be actually even more debilitating. So that's limited the doses of them to sometimes down to 25% doses of both. Actually, in our trial that we spoke of before, where we take sorafenib failures and then add in the everolimus, we actually have been able to maintain a little bit higher dose, and I'm hoping that that trial will complete soon so we can really show how well patients can do. So it's not impossible to put those two agents together, but it can be problematic, especially if you start up front. But in a second line setting, that might be a possibility. So those agents are very good, but not necessarily first line. But then the other exciting area, of course, is to start looking really at targeting other abnormalities. So if we take the subpopulation of papillary thyroid cancer patients, and now we say, okay, let's take a look at the BRAF mutated ones. So it's up to 50% of papillary thyroid cancer patients will have mutations in BRAF. And like melanoma now, not renal cancer, there is a very active agent which was FDA approved for melanoma being vemurafenib, and now actually I believe there's a second agent from GSK as well, another BRAF V600E inhibitor that's been approved.
Right, dabrafenib.
Dabrafenib, right. So those two together are actually both good agents to try in the papillary thyroid cancer, and a phase 2 study actually out of Genentech Roche has actually been completed as far as accrual, and we're still waiting to hear what the data from that is. And that's basically taken specifically 50 patients who have that mutation to see whether or not it's an active agent. So we don't have the data from that, but that's where we're heading. There's also an interesting study out of the University of Michigan where they're looking at PPAR gamma agonists for patients with follicular thyroid cancer who have the PPAR gamma PAX8 fusion translocation. So again, another subpopulation that might benefit from a specific intervention. But we don't really have the data yet. So those are still in the phase 2 realm, and figuring out which ones are active to go forward is still a scientific and clinical research question.
So PPAR gamma, this is a relatively new molecular target, at least to me. Tell us a little bit about that and what its role appears to be.
Well, it appears to help these patients have a mutation that tends to be more proliferative, and it's a follicular specific, a follicular translocation. And what happens is it's upregulated, but it turns out that if you give a PPAR gamma agonist, it saturates this pathway and actually shuts it down. So interestingly, these agonists are already used for diabetes. So these are diabetes drugs. So now there's a question of whether or not they might be useful in a therapeutic setting. Not unlike if you think about the mTOR inhibitors, which were originally used for immunosuppression, which have now also crossed over to be anti-cancer agents. But that's still very, very new. There are the other targets being the BRAF mutations. Those are probably the next one that we're really going to be targeting as far as figuring out what to do. And using the same approaches that were used in melanoma are also of interest now for us.
What about epigenetics? I've read some information that there is hypermethylation of some of the histones and all. Is there a role for some of the hypomethylating agents and HDAC inhibitors?
You know, interestingly, they've been studied quite a bit, and yet they have not shown the efficacy that you would have hoped that there would be. So that does not seem to be as good of a therapeutic target, at least as far as single agents go, and as far as actually turning, getting a response. And so because of that, they've kind of been put on the back shelf. I don't think that there are many open trials for them at this point.
Very good. So let's give our viewers some final take-home messages as to what the most important points of our discussion have been, and I'll just let you outline those for us.
Yeah, I think the most important thing is for patients who have been found to no longer respond to radioactive iodine and who have progressive disease or actually detectable disease, these patients really need to be referred to an oncologist who knows how to treat thyroid cancer, because there are now many agents out there and they are rapidly changing, and it's important that these patients get into a program that actually has access to a lot of these agents, because probably they won't need just one, they'll probably actually in their lifetime have two or three. So the first is that they get referred as soon as possible. The second is that they do get treated if they are progressing with one of the kinase inhibitors, and also that the person who's giving it knows how to control the side effects and that they do it well, because if they don't do it well, they may not get as good a dose in the long run. It may not be as effective. And last, that there's really some amazing things happening in the second line setting, either using combinations of drugs. And one of the things that I'll just throw in also is that we're actually looking, there's some agents out there that might increase uptake of radioactive iodine. And if we could do that, that would be wonderful. So there are many clinical trials out there that are actually showing new hope, not just in first line, but maybe in second and third line. And so it really is a new day for these patients. And I think they've got a lot of hope of good therapies in the future.
Very good. It's been a really exciting time, and I know in the years to come we're going to see more and more data coming out, and perhaps we'll have an approval within the next year, at least for sorafenib and possibly then for lenvatinib also.
Right. Well, that would be the first one in about 50 years. So
yes.
It'll be exciting.
Very good. All right, Marcia, thank you so much. This has been really interesting, and thanks to all of you for watching hopefully all three of these segments on emerging multikinase inhibitors in thyroid carcinoma. Thanks again.